Welcome to Chapter 2, Concepts of Osseointegration. At the end of this chapter, you will be able to define osseointegration, describe the process of osseointegration, and list the factors that influence it. One of the earlier definitions of osseointegration was originally proposed by Bernema et al. In 1969. He suggested that osseointegration is a direct functional and structural connection between living bone and the surface of a load-carrying implant. Later in 1991, another definition was provided by Zarb and Albrechtsen. They proposed that osseointegration was a process where new bone is laid down directly upon the implant surface, provided the rules for atraumatic implant placement are followed and the implant exhibits primary stability. The American Academy of Implant Dentistry defined it as the contact established without interposition of non-bone tissue between normal remodeled bone and an implant, entailing a sustained transfer and distribution of load from the implant to and within bone tissue. To put it simply, osseointegration is when you connect the titanium screw to the person's actual bone. The figure on your left is a custom-made implant made of CP titanium in the shape of a solid screw and configured with rough surface topography. In the implant device, the distance between two consecutive profiles of the pitch was 1.5 mm. A 0.4 mm deep U-shaped circumferential trough had been prepared within the thread region during manufacturing. The tip of the pitch was left untouched. Following the installation of the non-cutting device, the pitch was engaged in the hard tissue walls prepared by the cutting or tapping device. This provided initial or primary fixation of the device. The figures on your right illustrates a cross-section or a ground section of an implant with surrounding soft and hard tissues from a biopsy specimen sampled 2 hours after installation of the metal device. 2 hours after implant installation, the wound chambers were occupied with a blood clot in which erythrocytes, neutrophils, and monocytes or macrophages occurred in a network of fibrin. These figures illustrate a device with surrounding tissues after 4 days of healing. The coagulum had in part been replaced with granulation tissue that contained numerous mesenchymal cells, matrix components, and newly formed vascular structures in a process called angiogenesis. A provisional connective tissue or matrix had been established. After 1 week of healing, the provisional connective tissue in the wound chambers was rich in vascular structures and contained numerous mesenchymal cells. After 2 weeks of healing, woven bone formation appeared to be pronounced in all compartments, apical as well as lateral, surrounding the implant. After 6 to 12 weeks of healing, most of the wound chambers were filled with mineralized bone. Bone tissue, including primary and secondary osteons, could be seen in the newly formed tissue and in the mineralized bone that made contact with the implant surface. The factors that influence osseointegration are clinical factors, implant-related factors, and patient-related factors. Patient-related factors include systemic factors, history of periodontitis, and smoking. In patients with diabetes mellitus, it was found that successful dental implant osseointegration and high implant survival rates can be accomplished in subjects with diabetes with good metabolic control. However, dental implant therapy remains contraindicated in subjects with diabetes without good metabolic control. From a systematic review and meta-analysis study by Streetzel et al. In 2007, it was found that smoking is a significant risk factor for dental implant therapy and augmentation procedures accompanying implantations. There are several systemic medications that are found to influence osseointegration of dental implants. Sakakura and co-workers found that in 2007, administration of cyclosporin A in rabbits with integrated dental implants had impaired mechanical retention. In 1991 and then again in 1992, it was found that use of glucocorticoids led to loss of osseointegration. Ku et al. In 2004 found that alcoholic rabbits had significantly less bone density and reduced direct bone-to-implant contact. However, up till now, there is insufficient data to suggest that implant placement should be avoided in patients receiving bisphosphonates. From a systematic review and meta-analysis study by MOOC et al. In 2014, it was concluded that the risk ratio for implant failure in patients with aggressive periodontitis was significantly higher when compared to healthy patients or those with chronic periodontitis. Implant-related factors can be divided into material and surface properties and primary stability and adequate load. Bioinert material do not release any harmful substances and do not elicit adverse tissue reaction. An example of this material is titanium. Bioactivity is restricted to compounds of poor mechanical quality and can only be applied as a coating, such as hydroxyapatite. Rough surfaces will improve adhesive strength and favor bone deposition. This extends the bone-to-implant interface. Adhesion requires a chemical bond or a microporosity. This can be found in the microindentation between the bone and the metal. The primary stability of implants depends on their appropriate design and precise press fitting at surgery. It should build up enough preload to compensate for functional load. It thus determines not only the size, but also the direction of the forces that are considered to remain adequate. All these parameters must be specified, and this makes it understandable why immediate functional loading may be adequate for such systems as bar-connected screws, whereas others require a prolonged, unloaded healing period before a superconstruction can be installed. Surgical experience is an important determinant of implant success rate. It has been found that there is twice the failure rate in the first few implants placed by clinicians. Surgical techniques using cooling sterile protocols increases the success of the implants. Also, according to Sorelli et al. In 2004, primary stability is best achieved when the micromotion of the implant ranged between 50 to 150 micrometers. These are our references. Thank you for listening.